Okay, so I don't have, I have some disclosure. So I have a research partnership with Siemens. They don't pay me money, but they give me software that it's not being released on the market, and we've helped them develop some of the software. I'm part of the writing committee for the National Board of ECHO for the basic exam in the US, and I receive money from the University of Toronto that pays for some of my academic time. And what we're going to talk about in hopefully the next 40 minutes or so is we'll talk about the assessment of the right ventricle using transesophageal echocardiography, and most primarily about the challenges of assessing the right ventricle with echo in general, but in particular with TE. We'll talk about the rationale for RV strain measurement, and we'll talk about how to get it to work with different systems. And we'll finally talk about limitations and pitfalls, because as all techniques, there's limitations and pitfalls also for RV strain. So as you all know, and we've learned a lot from 3D echocardiography, the geometry of the right ventricle is extremely complex, and this is a rendering from a CT scan. We built this moving heart, and in the center is a 3D reconstruction of the right ventricle from echo. You can see that it's a very uneven shape, that it's extremely hard to reduce to a simple geometrical piece. So then using limited slices, then to be able to reconstruct the whole volume, it's impossible. So, and in fact, because of its funny shape, depending on how we cut the left ventricle, we see it in different shapes. So this is a 4-chamber view. You see that the right ventricle in a normal heart, it's kind of triangular. If you cut it in a short axis view, the right ventricle, it's actually crescent shape. So it's very unusual shapes. And it's not only the shape, but also the physiology of the right ventricle is very different from the physiology of the left ventricle. And the right ventricle works at much larger volumes and at much lower pressures. And it does respond to changes in afterload and preload way more than the left ventricle. And it does respond with acute dilatation to sudden increase in afterload, which is something that the left ventricle doesn't do as much. So when we assess the right ventricle, we obviously refer to our guidelines, and the American Society of Echo has guidelines for all the measurements of all the chambers. And in 2010, they came up with the latest version of the guidelines for RV assessment. And the guidelines are not specific for transesophageal echo. The guidelines are actually made mostly for transthoracic. And this is how you look at the right ventricle in a transthoracic cut. So the apex of the heart is at the top. And when you look at the right ventricle cutting in the same plane with transesophageal echo, we have the apex at the bottom and we have the atria at the top. So we're looking at the same structure in the same plane, but from different perspectives. And with transesophageal echo, trying to get the same measurements as we can get with transthoracic echo, we can for some of the measurements, and we struggle for some other measurements. And when it comes to assessing the change in area, or what we call fractional area change, with transesophageal echo, we're pretty good as long as we have a good resolution as we have in this picture, which obviously this is not my everyday echo. I picked the best echo I had. And so you can trace your endocardium in systole and diastole and calculate the change in percentage. When it comes to measuring TAPSE, which is the movement or the excursion of the tricuspid annulus through systole, then it becomes more of a problem, because you can see here that the tricuspid annulus moves in one plane, and if we use M mode as the cardiologists do with transthoracic, we're almost perpendicular to the movement. And here you can see if we get M mode, we get this wave here at the bottom, that it's not very accurate, because the line of movement of the tricuspid annulus is totally different from the line of incidence of the M mode. So people have tried different approaches to try to mimic the transthoracic images with transesophageal echo. And one way is to try to get a similar picture of transthoracic. And one way to get a similar picture is to go into the stomach, retroflect, and look at the ventricle from the bottom. And here, this is the right ventricular inflow view. We have the tricuspid valve annulus. This is the tricuspid annulus here. It's not on the left as in transthoracic, it's on the right, but the alignment of the movement of the annulus, it's much more similar or much closer to the incidence of the beam and possible M mod. So we can do M mod, which would be a bit closer to what we get in transthoracic. We can also use tissue Doppler and measure the velocity of displacement of the myocardium at the level of the tricuspid valve. Or some of the newer machines allow us to use anatomical M mod, which is a technique that uses a computer algorithm where we can put our M mod line wherever we want. So in this case, we can take this M mod line from here and flip it around, like we've done here. We flip it around and we align it where we think the movement of the tricuspid annulus would be. And so we have a displacement here, which is closer to what we get with transthoracic echo. One of the limitations from using transesophageal, mid-esophageal or transgastric view is that in the mid-esophageal view, we are measuring the tricuspid annulus in the lateral aspect, which is here. And then when we are looking in the transgastric, we're actually seeing the tricuspid annulus in the posterior aspect like here. And we know now from transesophageal 3D reconstruction of the mitral valve is that the lateral annulus doesn't move as much as the posterior annulus. The valve doesn't move altogether up and down, but it's tilting. So the lateral annulus moves much more than the posterior annulus. So if you are measuring if you want a measure that's comparable to transthoracic, you want to measure the lateral annulus and not the posterior annulus. One of the other problems with the current guidelines is that if you look at the guidelines, they come with numbers. And the numbers are identifying normal and abnormal. So most of the numbers, they only allow us for a qualitative assessment. We say, is it good or is it bad? So what would be an ideal measurement of the right ventricular function? So obviously something that's easy to obtain, that it's reproducible, that's a continuous variable. It doesn't just gives us good and bad, but gives us a spectrum of function, and that possibly correlates with outcome. So to find this ideal measurement, we can go back to basic anatomy. And like on a heart dissection, if you look at the wall of the right ventricle, it's much thinner than the wall of the left ventricle. Not only it's much thinner, but the architecture of the myocardial fibers is way simpler than the architecture of the myocardial fiber of the left ventricle. The left ventricle is fiber in many different directions, when for the free wall of the right ventricle, the fibers are mostly aligned from the tricuspid annulus to the apex of the right ventricle. So that's why we can look at the change in size of these fibers through the cardiac cycle. So if we slice through the free wall of the right ventricle, we can take the length of the fiber of muscle along this wall in diastole and in systole, and the change in length of these fibers through the cardiac cycle in percentage, it's what we call a strain. And in this case would be longitudinal strain, which means the change in length of the myocardial fibers along the wall here. So this red line, we don't usually look for this blue change in shape because there's not many fibers going across, and this would be radial strain. When, on the other hand, if we wanted to assess the ventricular function of the left ventricle, then we need to look at different shortening of fibers in different planes, and that's why we look at radial, circumferential, and longitudinal strain. But for the right ventricle, if we slice through here, we look at these myocardial fibers, see how it changes in size, and that it's probably a good estimate of the overall right ventricular function. So what happens in real life is that then in a four-chamber view, if we look at the free wall and we can actually anchor our pixels here to the length of the muscle, we can measure how the muscle shortens during systole, and shortening of the muscle, it's measured as a negative display, with a negative sign, and this is what we call a strain. So strain, when the muscle shortens, the strain or the change in length of the muscle is a negative value, which you can see here. Now, is the free wall strain a good enough measurement of right ventricular function? It's been studied for many years with transthoracic echo. There's not much with transesophageal echo, but on transthoracic echo, this is one of the many studies where they compared right ventricular free wall strain with MRI ejection fraction of the right ventricle, and there's a pretty good correlation of the amount of strain of the free wall with the actual fractional area change. What is a normal number for the free wall strain? And this is a large population study where they looked at the free wall strain in volunteers, and they also look at previously published literature, and they come up with the number 20. So 20% or minus 20 as a shortening or 20% change in length, that it's considered normal strain. We were talking about we want a value or something that gives us the ability to quantify a spectrum of function. And this is an animal study, but I liked it very much because this is a pig model where they were measuring right ventricular strain in the pigs changing the PEEP. And you can see that looking at the free wall strain, by increments of 5 centimeters of water of PEEP, there's a significant change in strain. So it's very sensitive measurement. So even just 5% of PEEP, it's actually has an influence on the strain measurement. Is it a good, or does it have any value in predicting outcome, or is it linked to any outcome? This is a very large cardiology study, prospective study on patients with pulmonary hypertension. In patients with pulmonary hypertension, different percentage of strain correlate with different outcomes. So the lower is your strain, which means the lower is your right ventricular function, which is kind of intuitive. But if your right ventricular strain is less than 15%, you have a way worse outcome over 20 months than if your strain is normal. What about intraoperative application of strain? This is another study where they look at preoperative strain on transthoracic echo of the right ventricle in patients undergoing left ventricular assist devices. And then I'm sure you have the same challenge here as we have in Toronto when we put LVADs. We're always struggling with the right ventricle. What is the right ventricle is going to do when we put the LVAD? Is it going to fail, or does the patient need a backup RVAD, or is it going to be fine? And actually, in a multivariate logistic regression analysis, looking at the lateral peak systolic strain, that was correlated as an independent predictor of right ventricular failure after LVAD implantation with a cutoff of 10. This is a study that we did last summer with one of my medical students who spent 2 months analyzing right ventricles and processing through a software to do right ventricular strain measurement. And we wanted to look at our lung transplant population and see what happens to the right ventricular strain before and after transplant in the operating room. And what we saw here is that there's and we also looked at fractional area change, S prime and TAPSE. And while TAPSE and S prime before and after surgery, they don't have a significant change. This was pre-op, before surgery and after surgery. Fractional area change and strain did change significantly before and after, which is what was expected because we're giving these patients a whole new pulmonary circulation. So we're expecting the right ventricle to be much happier after. We look at the same thing in patients who underwent pulmonary endarterectomy. We do about 50 pulmonary endarterectomies a year at Toronto General Hospital, and it's actually a Swiss surgeon who does it from Geneva, Marc Deperron. And while, again, S prime and TAPSE didn't really change significantly before and after, there was a significant change in fractional area change as well as in strain. And finally, we compared the change in strain before and after lung transplants compared to the change in strain before and after pulmonary endarterectomy. And as expected, we found that if you do a lung transplant, the degree of change of strain is much more significant than the change after pulmonary endarterectomy, which is what it's sort of expected, since in pulmonary endarterectomy patient we try to scrape as much as possible, but some disease it's always left behind, when in lung transplantation we change the whole pulmonary circulation. So how do we measure strain on the right ventricle? So the first attempt to measure strain and the first technology that allowed measuring strain was based on tissue Doppler. So, there's a nice feasibility paper that was published by Claude Toussignan, who's one of my colleagues from another hospital in Toronto, that was published a few years ago in Anesthesia and Analgesia. And what they did is, it's using a right ventricular inflow view from the transgastric view. You have the tricuspid annulus here, which you've seen before. You get the myocardium here of the right ventricle, and what you do is you use tissue Doppler. And use tissue Doppler, you measure the velocity of displacement of the myocardium during the cardiac cycle. And as we all know, the myocardium at the level of the annulus of the tricuspid valve will move towards the probe, so we have a positive deflection in systole, and the peak velocity is what it's called S prime, and it correlates with right ventricular function. How can strain be measured at this level, at the level of the myocardium next to the tricuspid valve? So you can use a function that's only available on the GE system, as far as I know, at least from the system we have, the only one that does it is the GE, and you put a gate or an area of interest on the myocardium where you want to measure the strain. And what you do is, you have something like this that has two dots. And what the system does, it's basically measuring the velocity of movement of one dot and the next dot. So then what it does is, it looks at the difference in velocities, and by looking at the difference in velocity, it can tell whether these dots are coming closer together and how much they're coming closer together. And then the displacement of these two dots towards each other is displayed as a negative thing, which is the strain. And in this case, this is a curve of a normal strain, which is more than 20% or minus 20, which is here. So it's a complicated system. What we're looking at the strain at this point versus this point. We're not looking at the strain from the apex to the base, but we're looking at 2 points kind of close to each other. You can make this gate a little bit bigger, but you'd have to look at 2 dots here, 2 dots in the middle, and 2 dots at the apex. Now, the tissue Doppler strain, it's obviously has a problem because it's only available on certain machine. One of the problems is that you can only measure it with TEE, with the RV inflow view from the transgastric, and as we saw before, what you're looking at, it's not a true free wall on the lateral wall, but you're looking at the posterior wall of the right ventricle. You need a good alignment because it's velocity based, and it's angle dependent because it's based on Doppler. And you only measure single points at a time. So what happens is that, as you can see, technology has progressed to the point that, like outside of medicine, we can track points. And you can see here that, like, we're tracking some of the face feature, some of the features here of this guy. And the computer can track points in space. It can track points not only in 2-dimensional space, but also in 3-dimensional space. So what if we apply this to the myocardium? So now, instead of tracking the rim of our mouth or the eyes, we can track the speckles within the myocardium. And these speckles corresponds to a certain point of the myocardium. So what happens is, I can anchor my cursor to one point to one of the speckle. I can anchor another point to another speckle and see how these 2 points move close or away from each other. So this technology has been applied to the right ventricle, and one way to apply it to the assessment of the right ventricle is to use in the EPIC, Philips EPIC system, it's called advanced 2D quantification. And with advanced 2D quantification, I can select 3 points. That's the apex of the right ventricle and the annulus of the tricuspid valve. And if I process this, I got something like this. So you can see that I'm tracking the tricuspid annulus and I'm tracking the apex, and the software tells me the distance between this point, this blue point, and the apex at all time, and the maximum distance is now what we know as TAPSE. So I'm measuring TAPSE, measuring the true change in distance between the tricuspid annulus and the apex of the ventricle. And this is something that was actually the group from Nebraska that led by Sasha Shilkot. They did in the operating room, they took consecutive patients coming from coronary bypass. They did transesophageal echo, they got a 4-chamber view, and then at the same time, in the same patient, they did a transthoracic echo, apical 4-chamber view, and they compared the apical 4-chamber view transthoracic TAPSE with the TAPSE measure with tissue tracking, and with the TAPSE measured with M-mode without any angle correction. And guess what? There is a very good correlation between tissue tracked tricuspid valve annulus and the transthoracic TAPSE. But what we actually want to do is we don't want to look at the tricuspid annulus and the apex alone, but we want to see how all the muscle along the free wall actually is moving. And one way to do it is the only way to do it in most systems is actually to fool the system. Because the system itself, the Philips and the GE system, don't have anything that's called RV strain. They have something that's called LV strain, which is actually not even called LV strain, has another funny name, but the only way we can get RV strain to work is to tell the machine that what we're looking at is not the RV, it's actually the LV. So in particular, with the Philips system, this is what happens. You have to tell the system that you're looking at a mid-esophageal long axis view. Then you have to identify the tricuspid annulus and the apex. Then the software overlays points on the myocardium. Now we need to adjust the region of interest to include the myocardium alone, so we have to move it around. And when we hit process, then you can see that now this overlay is following the myocardium. Now, because what we're really interested in is the free wall strain, we're not interested in the septum because the septum belongs to the left ventricle. So all we need to know, or all we want to know, is the free wall. So we exclude the segments on the septum, and now what we have here as strain is an average strain of only these segments, which in this case it's minus 31, which is normal or abnormal? Normal. It's pretty normal. So more than 30 is normal. Now you can see now that we have a normal strain. This is how it looks like. You have a global number minus 33, and this is an abnormal strain where you can visually see that this tricuspid annulus doesn't move much, but the whole actually free wall doesn't move much, and in fact the strain is only 15 in this case here. If we are working with a GE system, it's a slightly different process. So what we need to choose is we need to choose something that's called AFI, and we need to tell the system this is the mid-esophageal long axis view. Same thing, we pick the tricuspid annulus, we pick the apex, and then it overlays the dots, it processes it, and here it tells us how well the tracking is, and then we can put it forward, and it's going to overlay the color of the strain. And now again, if we are interested in the free wall alone, we need to go back and eliminate the middle segments, but here you already have for each subsegments of the right ventricle, you have the actual number of strains. So here I went back and I'm going to eliminate the septum. The septal segments that I'm not interested in, if I approve, now when I process it, it's going to only show the free wall. And I have to go back into my outline here and look at this point here and see where it falls, which in this case was pretty normal. so this is the software from the GE system. GE has a package for the actual RV strain. And instead of giving 3 points only, I have to follow the myocardium. And I have to follow the endocardium at the edge of the endocardium and the blood pool. So when I analyze, the software is tracking the walls, and it adds these arrows that are the velocities for each of these points. And then once you display it as parametric, you have numbers of actual peak percentage strain, which you can measure here. And again, you have a curve with the dotted line is the average strain for the whole free wall. And here again, I've eliminated the septum. Finally, the other software that we have, and that's what we use for the studies on the pulmonary endarterectomy and the lung transplant patients, it's called Echo Insight. And this software allows you to analyze any image that's been previously acquired. So you can take like any patients that you have on your server, as long as you have a good enough 4-chamber view, you can put it into this software, and then what the software is going to do is going to do a strain of the free wall, and what it does, it also calculates automatically your fractional area change, TAPSE, based on tissue tracking, and this red arrow that you can see here measures the S prime. So one of the limitations of using strain that I find people have is that each vendor has a different name for it. So you can see that like Philips, for example, calls it automatic cardiac motion quantification, ACMQ, when GE calls it AFI, automatic function imaging, and then GE calls it VVI, velocity vector imaging. Each of them have a slightly different algorithm to calculate the strain. The Philips and the GE software are based on they are actually made for the LV, they are not made for the RV, while Siemens says it's made for the RV. Why did this all happen? This is the same issue we have with 3D Echo. This is the first one who came out with technology, gave it a name, patented the name, so no one else can use it. So the other vendors, when they come up with a similar technology, they need to use a different name. But at the end of the day and we'll see that it's not really the same thing, but it's kind of the same thing. So then what makes it confusing is that each vendor displays the strain in a slightly different way. So this is GE, where you can have the strain for each segment here. And if you want to know the global longitudinal strain, you need to scroll and get the point of the lowest point here. We also have a sort of parametric imaging with color and changes strain over the cycle. Philips makes it relatively easy to understand. You have a longitudinal strain, and here you can see the values for each segment, and you have also a graphic representation, and Siemens has a very similar outline. Now, as I said, they all have kind of the same algorithm, but they do have different algorithms. And in fact, this has never been done for right ventricular strain, but for left ventricular strain, there's a group from the European Society of Echo and the American Society of Echo who did inter-vendors comparison. And actually, they looked at all different vendors who have a strain package. And the correlation, taking the same data set and analyzing it with all the different packages, the numbers that you get are kind of the same, but they're not exactly the same. There is a little variability between vendors. And what's also what I found interesting is that actually not only there's a variability between vendors for the absolute number, but they looked at inter-observer errors. So we got one data set, analyze it on the Philips system. We got 3 people from you to do it, and all 3 of you, you get similar numbers with some vendors, then more similar numbers with some vendors than with other vendors. And that probably has to do with the fact that the user interface or the way the tracking works, it's slightly different. So with some system, it's simpler to get a strain, and then everybody gets the same numbers. With other vendors, not everybody gets the same number. So what's the secret to get a good strain measurement? So the first step is you need to get a good four-chamber view where you actually see the right ventricle. And in this case, there's two really poor four-chamber views for the right ventricle. So, and here you can barely see the free wall of the right ventricle, right? And here the problem is that tricuspid annulus is most of the time outside of the plane, outside of the screen. So you cannot track the wall all the way to the tricuspid annulus. So basically, whatever you can see, you can track. So if you don't see the wall, you can't track the wall. The other problem is tracking. So tracking is how well your software is following the myocardium. And you can see here how the my green dots, they don't really move that much when my tricuspid valve moves way more than the green dots do. So the tricuspid annulus is moving much more than the actual dots. So that means that the software, the computer, is not really following the tricuspid annulus. So that means that this is going to give me falsely low strain values. And in fact, if you look at this yellow, the number is -7. But if you look at the tricuspid annulus, it looks pretty normal movement. So this is the problem, is the fact that the tracking is not so good. One of the problems with the tracking is the fact that for some vendors, like Philips in this case, it's really up to you. So it's very subjective. So it's you looking at the images and saying and deciding whether the tracking is good or not. So you can see and say, well, is the tracking good or not? In this case, you have to pick it up yourself. Which, I mean, as you do it over time, then you get good at it. But on the other hand, it would be good if you had some other measurement that tells you whether the tracking is good or not. And that's what GE has, and it's the only vendor that has a tracking quality assessment. So when you put your dots and then the software tracks the walls, it gives you these check marks here. So where it's green, it means that the tracking is pretty good. When it's red, the tracking is not good. So what can you do? You can try to adjust the dots to make the region of interest wider or smaller until you get all red-green check marks. Some of my colleagues give up by the time you actually get all green. And sometimes, for as much as you try, you never get all green. So, but what happens is that, yeah, okay, it makes my life harder, but if I do get all greens, then that's a pretty good tracking. If I don't have all greens, then I can always override it. So if I look at the segment and the software says not good, you can click and say, no, I think it's good. So you can overdrive the software, but it's not something I would advise anybody to do. The other thing that we need to keep in mind is that, yes, strain, it's angle independent because we're not shooting at the myocardium measuring the velocity. So we don't depend on the angles. We need to correct to get a good velocity, but we're tracking the speckles. So it doesn't matter in which direction the speckle move. We're always measuring the speckle in respect to each other's, not in respect to the probe. But that's also demonstrated for the left ventricular strain not to be entirely true. And actually, this is a transthoracic study where they look at the same heart, tilting the probe slightly. You see, this is the left ventricle is vertical, this is sideways, and whether it's vertical or sideways, the numbers are a little different. And this is something that needs to be kept in mind. And here, I was trying to see whether anecdotally I could prove the same with right ventricular strain. This is the same patient trying to get a slightly different views, and I did get I got different numbers. So this is 26 and this is 33, but this is the same patient, exactly same patient. Both cases are within normal, but if this was for sort of research purposes, being able to reliably measure the same numbers would be very important. The fact that the strain is angle or relatively angle independent doesn't mean that it's not load, it's load independent. So strain, it is a load dependent measurement. So depending on the loading condition, we may have different strain measurements. So in the same patient, whether the filling of the ventricle changes, we'll have different values for strain. So finally, we are looking at the strain in 2 dimensions. So I get a slice of the right ventricle, and we look at the strain on this slice. So we're only looking at the movement of these dots along the line on this plane, right? But there are the movement of the myocardial fibers of the free wall, although they are relatively well aligned with this plane, they are not perfectly aligned with this plane. And in fact, for transthoracic echo, there are softwares, they are mostly used for research. I'm not aware of any software integrated into any machine where they've looked at the speckle tracking in 3 dimensions of the right ventricle. And by chance, for other purposes, we were doing a big experiment, and what we did is we put crystals on the surface of the heart at the level of the tricuspid annulus here, and this is the apex, and this is mid ventricle. So, and I looked at the movement in 3 dimensions of these crystals over a period of time. This is a pig heart we've done bad things to, so this is not a normal functioning right ventricle. But you can see that the movement of this 0.8 and in respect to 2 doesn't really move much, which is what it's expected. It's the apex, but the base of the tricuspid annulus, the movement, it's not just on a straight line. It's much more complex. So definitely there may be a role for 3D strain in the right ventricle, and applying 3D strain to the right ventricle, we may actually come up with like patterns or have a bit more information. So just as my last slide, I wanted to summarize some of the difficult things to get along with, which are the definitions. And when we talk about RV strain, we normally talk about peak longitudinal strain. So when we talk about the strain along the free wall of the right ventricle, and we look at the peak, the maximum number. And as we said, it's less than 20% is normal. When we talk about strain rate, which I haven't mentioned at all because we don't really use it much in clinical practice or doesn't have immediate clinical application, we talk about the change in strain over time. And when we're doing tissue tracking, that's what we base the strain right now in modern machines. Tissue tracking, it's also called speckle tracking, and it's also called, in some papers, 2D strain. When you hear about 2D strain, what is 2D strain? It's 2D strain is speckle tracking, and it's different from TDI or tissue Doppler-based strain, which is sort of an older technique that few people know. One thing that I find that it's also confusing is the fact that a normal strain is a negative number. So minus 20 is the cutoff for normal. So a more negative strain, like minus 35, it's a better function than minus 20. So sometimes that causes confusion because people may not think about the negative value, and then a higher number, as long as it's negative, it's better than a lower number, as long as it's negative. Obviously, a positive number, 0 would mean no movement, and positive would mean that the 2 points are moving away from each other, right? Which we very rarely see. So if you do the strain and you look at and you have positive deflections, that's usually because you really need to make sure that that's true. So in summary, I think that 2D RV strain based on TE, it's feasible. It gives us a continuous variable. It's reproducible. There's a confusing proprietary copyrighted vocabulary, so each vendor calls the things differently. In most vendors, we apply LV models to the right ventricle, so the numbers we get, they're not really the geometry, doesn't account for the geometry of the right ventricle. There's slight differences between vendors, and we are lucky to have softwares that allow us to do offline analysis on and retrospective studies on large databases. So thank you very much. We have a website which you may or may not know, but I've sort of seen it. I've contributed to the creation of this website with Annette Vegas, who's my mentor and my colleague. And we also have a website of the lab, which is the topic of tomorrow's talk. And we have a conference in Toronto every year in November. You're very welcome to come. It's not a good time of the year, but for coming to Toronto, but it's cheap. The flights are cheaper, and I'm also part of the organizing committee of Echo Week for the SCA, so I'll be there if anyone is coming. And obviously, any of you who wants to come to visit our hospital, regardless of these conferences, is very welcome. You can come, just send me an email. Thank you very much.